So it's well known that more wealth is correlated to better health. The wealthier you are, the longer your life expectancy, the better your health is. It's a term of art called the social determinants of health. But the converse is true as well. Better health can lead to improved wealth. So, of course, this applies to the 9% or so of Americans who are uninsured. They, of course, bear the full cost of any healthcare costs. But fully 43% of Americans are now covered by a high deductible plan, which means that their insurance doesn't kick in until they hit a certain level. For 2020, that level is at about $1,400 for an individual and $2,800 for a family. I think, as you may know, 70% of Americans have less than $1,000 in any sort of liquid savings account. So it isn't surprising then, given these two facts, that the vast majority of bankruptcies in this country have something to do with healthcare costs. Indeed, about 2/3 of people who file bankruptcy cite healthcare costs as a major contributor. Poor health obviously can mean that you're out of work and end up on disability. And even when you retire, Fidelity estimates that the average male-female couple retiring in 2019 should expect to spend over $285,000 of healthcare costs over and above what Medicare will pay. And that doesn't even include any costs for long-term care, such as nursing homes. So if we are going to want to help Americans build and preserve any sort of wealth, we have to focus on their health, improving how healthy they are, and if they get sick, optimizing the amount of money they have to spend. So unfortunately, the current US healthcare system does a lousy job at these. The system is largely built around fee-for-service payments, where doctors and hospitals get paid for each thing they do. Therefore, what they do is they do more of everything they do. So to help address this, what we've responded to is by saying we're going to give patients, quote, more skin in the game by creating these high deductible plans and put as much of the economic burden on them. This would be fine if we thought that they could actually help make these decisions. The problem is medical care doesn't really work this way. There are huge asymmetries of information. The doctor knows much more than you do. There are huge power asymmetries. Imagine you lying in a hospital bed trying to comparison shop while the doctor's standing over you with a white coat and a big needle in their hand. And pricing is completely opaque. There's no way that you know what any sort of comparison pricing is. What's happened is we have moved in healthcare similarly to what we did in retirement, from pensions to 401k programs. So my father worked for a hospital system his whole life. He worked there for 20 years, and the deal was you work for us for 20 years, we will take care of you in retirement, a defined benefit. What happens now, my employer, is we get a defined contribution. We're going to contribute this much to your 401k plan, but it's up to you to decide how to invest the money, and good luck to you whether you have enough money left at the end to retire. So what's emerged in financial services is a whole network of financial advisors to help consumers make these choices and end up at the right place. So what I would argue is that's what we need in healthcare. A set of financial advisors, or what I call healthcare advisors, to help you make those decisions. And our proposition is that primary care is the best place to do this. So the problem, though, is current primary care is not at all equipped to help people with it. Most primary care is paid fee for service. You have 7 to 10 minutes with people. You are not able to really have the time or the information to help them. You're reactive, it's fragmented, and too often primary care doctors these days don't work for you. They work for the hospital system, where they're actually encouraged to order more tests and procedures often, or they work for the health plan, where they might be encouraged to not order more tests or procedures. The very simple answer is what you need as a consumer is a primary care doctor who works for you, with the period at the end of that sentence. And then what you need is that primary care doctor to work very differently, to really focus on your health and helping you navigate the system, not just writing more prescriptions. So about 9 years ago, I started a company called Iora Health, and the whole goal was to start a primary care system that actually did this, serve as financial advisors or healthcare advisors for patients through the system. So several differences. So the first thing is how we're paid. We don't get paid fee for service per thing we do. We think that puts us in conflict with our patients. We don't get paid more for doing more. What we do is we get paid a fixed amount, and we get paid to help you navigate the system better and lower your healthcare costs. Now, all of a sudden, our incentives are aligned, and we don't work for a hospital or a health plan, we work for you. Second is we then completely change how we organize the practice. So, of course, we have doctors. I'm a doctor. Our job is to help prescribe and tell you what you should be doing. But the hard part isn't doing that. The hard part is actually for a patient, how do I execute on this plan? So we have people we call health coaches who can work with you one-on-one to help you actually execute on the plan. Take your medicines, know what to eat, know what to track, hold your hand when that's the right thing to do, kick you in the behind when that's the right thing to do. We also have behavioral health specialists in the practice to help with depression and anxiety. We have social workers who can help with any sort of programs you might need to be hooked up with. We can communicate not just by having you come into the practice, but by email and text and video chat. We get patients together to learn from each other. We'll reach out and see you at the home if you need to. If you need a ride, we'll send an Uber to pick you up. Your daughter can Skype in for the visit. You can see your whole medical record online. This is not a little different. It's completely different. We build a de facto narrow network, a set of specialists and hospitalists who we collaborate closely with, again, to help you get the right healthcare at the right cost, not actually trying to gin up bills for someone else. We also have put a different sort of IT platform to really help us do this. The typical IT platforms for primary care are built to help people document, code, and bill hire. We don't care. We have one that helps patients engage in their care, understand what they're doing, what they're spending, and optimize that. So how does this look? Let me tell two stories to really illustrate both the failings of the current system to help preserve patients' wealth, as well as what we can do to help. So the first one was a patient that we saw who came to us in Boston. And again, step one is really to make sure that people are getting the right things done that they actually need, and not get the things done that they don't need. So this practice in Boston was one of our first retail practices. People paid $40 or $50 a month to come see us. And we had a gentleman come to us and said, "Can I buy a membership for my mother? She lives in New Jersey." I'm like, "Why would you want that?" And he said, "Well, because she is old and I don't trust her doctors down there. She always asks me for advice. Will you do it?" I said, "Sure, I need to meet her. She needs to agree." So she comes in to see me. And she was a charming little old lady in her late 70s, little arthritis, little hypertension, and a few meds. I wished her the best of luck, and she gave her my number, and she went on about her business. About 3 months later, this gentleman called me up, and he said, "Rushika, my mom called me. She's about to get a pacemaker." I'm like, "A pacemaker? She seemed fine to me. What's happening? I don't know. Can you check?" I said, "Absolutely." So I pick up the phone and I call the lady. So what had happened is a week earlier, she had urinated, looked in the toilet bowl, and noticed some red in the toilet bowl. So like a good Scooby, she said, "I'm going to go to my primary care doctor." Does the primary care doctor saw red in the toilet bowl? And the primary care doctor said, "You should go see a urologist." So goes to the urologist. The urologist said, "Ma'am, he's a hammer. The word looks like a nail. Ma'am, this could be cancer. I need to do a cystoscopy, put a camera up your bladder to see if it's cancer." Now, the most likely thing this is, red in the toilet bowl for a little old lady, is what's called beet urea. She ate beets. Completely harmless. Second most common thing is this is a urinary tract infection. She probably had a little bit of a UTI, and you could check that very easily with a dipstick. Third is she has hemorrhoids. You can check that very easily too, but this primary care doctor did none of those, just sent her straight to the urologist. So, urologist wants to get by the way, I asked her what happened to the red in the urine. She said, it went away the next day. This is all a wild goose chase. So urologist wants to do a cystoscopy, but ma'am, you're old. You need to go to a cardiologist to get your heart checked out before I do this cystoscopy. Goes to the cardiologist's office. Cardiologist nurse does a review of systems. "Ma'am, do you ever feel weak or dizzy?" "Oh, sometimes, Sonny, I feel a little weak and dizzy." He says, "You should do a Holter monitor. It's a patch that you wear to monitor your heart rate." So she takes it home, wears this patch for a day or two, comes back. He looks at it, and she has what's called asymptomatic bradycardia at night. Her heart rate goes slow when she sleeps. Completely no symptoms. He said, "Ma'am, that could be dangerous. You need a pacemaker." So that's where she ended up where she is. So I said, wait a second. First of all, it's not clear why we're doing any of this workup, because this went away, and this is a wild goose chase. Number two, they called a friend who's a cardiologist at a big teaching hospital. Is this a asymptomatic bradycardia at night an indication for a pacer? Absolutely not. The risk of sticking a trocar in her groin, putting metal in her chest, way outweighs any potential benefit. Third, I said, let me look at her medication list for her hypertension or high blood pressure. She's on a medication that actually slows her heart rate down, called a beta blocker. We could switch that, put her on something else. So I called the cardiologist, said, I work with the family. We politely decline your pacer, and next time you should check the med list before you prescribe a procedure. So this gentleman was very thankful. He said, well, you just saved us, a huge procedure, a lot of money, and not to mention my mom's health. He said, tell me, does that cardiologist make money off the pacer? Absolutely. Does that urologist make money out of the cystoscopy? Absolutely. He said, what I love about you is you don't have a dog in this race. You work for me and you work for my mom, right? That's what we need. Second is, I think, apart from whether you get the right procedure, is pricing. Pricing is egregiously different, particularly in the commercial space while you're working. We had a practice up in New England, and we were working with a big health system. And what we would do is we would draw blood in our office and send it to their lab. So a patient came in one day, and she had one of these high deductible plans. She said, Doc, you're going to order a Chem 20, a really simple test. How much will that cost me? I said, that's a really good question. Let me figure that out. So I called the lab at this academic health center. I said, we're about to order a test for this lady. How much will it be? And he said, doctor, it's really complicated. I said, don't patronize me. You will send this lady a bill. That bill will have a number. You expect her to pay that number. I want to know what it is. You go to a restaurant. You order a steak, you want to know what the price is before you eat it. He said, I won't tell you, why don't you call the health plan? I called the health plan, Anthem, and they said, our prices are secret. I was like, how can the price be secret when the patient is expected to pay the amount? Get every excuse in the book. I said, you idiots, I have all your claims data. We get all the claims data for their prior claims. I want to figure this out. So it turns out this test costs about $20 or $30. The price that this health system was charging for it was $150 and hiding it. And by the way, incidentally, if you're a poor uninsured fool who walks up, that price would be $320. So this is a 10-to-1 difference in pricing, which is kept opaque, right, and hidden. So really, we think that for patients, if they want to try and improve their wealth, whether they're working or retired, that actually paying attention to healthcare and your healthcare costs, what you get, whether you need it, and if you do need it, getting in a place where the price is reasonable is really important. And that it's really hard for patients to make these decisions by themselves. We believe primary care practices like us, equipped with the right sort of tools, the right incentives, the right payment models, are a hugely important way to help patients actually make these decisions and improve their health and their wealth. Health and wealth are inextricably linked. We believe new primary care models like ours are key to helping consumers optimize both. Thank you very much.